Acknowledgement. So we wish to acknowledge that the land on which we gather is the traditional and unceded territory of the Coast Salish people, including the Musqueam, Squamish, and Tsleil-Waututh nations. If you're joining from another region, please feel free to enter that in the chat. Next slide, please. The agenda for today. So we're just going to go over some housekeeping instructions, purpose and guiding principles. We've gone through that a couple times, so I'm just going to breeze through that, those slides. And then just the validation of the workflow, so referrals, registration, scheduling, the provider workflow for orders and documentation, some forms that we're going to upload into our form fast within Cerner, validate some user positions, locations and counter types and medical service. If we want, we could take a break if the group decides, and then we're going to validate the faxes and printers, some clinic information, discharge reports, and the end-to-end workflow in a visual representation on the slides. And then we'll have some time for questions and next steps. Next slide, please. So again, just some housekeeping. Please have your first and last name displayed for proper follow-up. Also, please mute your microphone when not speaking. And you can also add some non-urgent questions to the chat. We will be monitoring the chat as well. And then you could also raise your hand as well. Just some introductions. I know we all know each other from previous sessions, so I'm just going to quickly go through our SMEs. Catherine is on leave, but we have the director of the clinic, Monique Davidson. Thank you. The palliative clinical resource nurse, Alexandra. Joan from long-term care as a palliative clinical resource nurse. We have Dr. Lois Ado as our physician provider in the system. And Sabrina will be joining us hopefully shortly. From the clinical informatics side, we have our manager, our lead, Hilda Chung, Sarah Newfield and myself as specialists, some BAs from registration, Jocelyn and Danica. From our provider adoption team, Megan and Jessica. Our BAs, Dolores, and our AA, Tyler Childs. From scheduling, we have Laura and Cynthia, and our provider education team, Harmon Deep. Have I missed anybody? Has anybody, if so, if you could enter that in the chat, or if you want to, I'll give a brief moment here just for everyone to kind of catch up. I know time is of the essence. Some of us are on a time crunch here.
And it looks like we also have Mary Chan in the meeting as well. She is one of our clinical informatics colleagues who gives me lots of support as a learner. So welcome, Mary.
Perfect. Next slide, please. So the purpose, we will review the completed CST clinic Cerner build and the workflow for this clinic. So our scope includes registration, scheduling, the home visits, documentation, and discharge and follow-up. Some guiding principles for change. So I'm just going to breeze through this. Our guiding principle number one, no change for the sake of change. Cerner is a program from the US, and we make changes to the model content if there are any safety, regulatory, financial, or content that doesn't exist within the system that's kind of out of the box. Next slide, please. Our focus is on enterprise design, so we're configuring for enterprise-wide, meaning all three health organizations, that's PHSA, PHC, and VCH. And we will prioritize our design topics based on what is needed first in order to go live at each site chronologically. And other design topics will follow a specific schedule as to when these will be accomplished in alignment with the go live roadmap. Next slide. And our priorities are must-haves. So these are things that need to complete it prior to the activation. Nice to have are things that are changes and additional functionality that will be reviewed and evaluated post activation. We are really working towards a functional system, and there will be opportunities to fine tune the system once we get everybody using Cerner. Next slide. And then it's back to you, Sarah.
Thank you. So since we have Monique for 20 minutes, what we're going to hit first is the referral, registration, and scheduling workflow. And so just a brief reminder in kind of a laid out visual format before we go through a Cerner demo, we have two options for registration and scheduling. So they all start the same way with a referral from a clinician that is known to the PCRNs, whether that's long-term care or home health. The PCRN does their patient history review, could be on Paris, Care Connect, on Cerner once we're live, and makes a decision on eligibility based on the result of their chart review and their interview with a home health nurse or long-term care clinician. Of course, if they're rejected, they will communicate that. But if they're accepted, option 1 includes creating an appointment block in Cerner and sending a message to the clerk to say, hey, I've made this block so it doesn't get taken by anyone else. Can you please register the patient by creating this pre-outpatient encounter? On the clerk end, of course, they have to view that message, create the encounter, and then send a message back saying, I received your message and now registration is complete. Finally, on the PCRN side, they must view that message and then schedule the client in the scheduling appointment book. They do have to be sure that they select the correct encounter. As we go on in the future with Cerner, clients can have multiple encounters with multiple sites that are live with Cerner. So that is a really crucial piece of that workflow. Hilda, should we go straight into a demo maybe just to avoid confusion? Just thought of that now. Maybe that's a good idea. So what I'll do is just get my appropriate windows open so it's all making sense to you. All right, so I have reviewed my client, Ms. Jyoti, and I've decided that she is appropriate for a home visit. And I'm looking at her availability, and she tells me, and her family tells me, that January 30th, the Tuesday, in the morning is a good appointment time for her. So I see that Dr. Alexiadis is on shift for home visiting, and they said, yep, we'll take a 9:30 visit. So what I'm going to do, take this here, just make sure my location is correct. And as the PCRN, what I'm going to do, instead of a specific appointment type like newer follow-up, is create a block time. And since I'm the one who's doing the booking, I don't need to tell the clerk much more than that. I just need them to register. And I'll put in the client's name as well. Just copy it over. Dr. Alexia is at 9:30. And even though it's just a block, I do still need to confirm it. Now I've got that little dialog box there and a border, then I know that we're locked in and I don't run the risk of anyone else taking this appointment time while I'm waiting to confirm this appointment. So what I'm going to do now is send my message to tell the clerk, hey, I need you to register this patient. And I'll just make sure I'm messaging my correct clerk. In 1 second. And of course, you can save your favorites for folks that you work with. All right, so I've got my clerk's ID in the to field. And what I'll do is say, hi, Cynthia, would you please create an encounter for following client so I can book them. And the piece are in. I can say I have blocked them for January. It was the 29th, maybe it was the 30th. 30th. At 9:30. And I've sent that off. And now, Cynthia, I will pass it off to you to show how you receive that message.
Okay. Hi, I will be your clerk for the day. Let me share my screen here. Okay. So as the clerk, I am always in my message center and actually my future request list, which is back over here, and then the chat book as well. So I do see that I have a new incoming message. I'm going to go ahead and read that in message center. Let me make this a little bigger. So I see that I have I need to book an appointment for this patient. I've got the MRN. I've got the patient's name, and it looks like they booked it for January 30th at 9:30. So I'm going to go ahead and I'm going to grab this patient's name. Maybe the medical record number would be better, whichever one is part of their workflow. And then I can go to the 30th and I can see that that is blocked, although it's not associated with a patient at the moment. So that's the part that we need to get moving on. So I'm going to book a palliative new for this doctor, and oops, that got grabbed the MRN.
Oh, and Cynthia, sorry to interrupt your flow there. For this initial workflow, we'll demo just you creating the encounter, and then I'll book as the nurse.
My bad. Okay.
That's okay.
Apologize.
Sorry to interrupt you there.
So all I need to do then, that's easy enough. Right. I'm sorry. Okay, so all I'm going to do is go up here to this little patient head. That's what I clicked on, the little icon. That's going to take me into an encounter, a registration encounter. I'm going to click add encounter because we need a new palliative, RHS palliative, home visit. And that's going to pop up a screen. So I want to make a pre-outpatient. Click OK. Load my registration screens, and really in here, if the patient's been here before, there's not a ton I need to do. Are these pre-recurring? Sorry, I think I asked that every time.
Pre-home care.
The pre-home care. Thank you so much, Jocelyn. And the medical service is, I think palliative. Is it?
Yeah.
Sorry, palliative. And then the reason they're coming in, whatever it is that you're supposed to say. And I could have grabbed that from the message center as well if it's in there. I don't know if it is, but I can grab that information, anything that's put in there. And I'm going to go ahead and complete this. This mid time, we can update that because I could have put the 30th. Sorry, I'm a little rusty at this.
That's okay.
Put the 30th in there at 9:30 because I know that's when I'm going to book the appointment, and I'm going to go ahead and complete this. Is it thinking? And then I have an encounter number, and I'm going to grab my message center back. And my encounter number is reply in message center encounter. It was 74. Sorry, I don't think they let you copy and paste. 74 with 1, 2, 3, 4, 5, 6 zeros. And then it was 8, 8, 8, 5, 1, 8. Patient. And then I can just send that off. Click OK here. And then I'm just going to look back in Power Chart at my messages, and that should be off and running to the nurse so I can pass it back.
Oh, of course, I'm on mute. Okay, I'm back in my inbox. First thing I always want to do is refresh. I can see I haven't refreshed for 6 minutes. So let's have a look. Oh, I'm still in sent. There we go. All right, and here she has noted that she's created the encounter. And so now it's my turn to schedule the client. So what I'm going to do is, now that I know that the encounter is created, essentially registration has happened, I can remove this block so that I can book it. So they always want you to give a reason when you cancel. I'll just say appointment modification. All right. We'll start with the client's name, click those 3 dots to look them up. And here's Ms. Jody. So that encounter number that Cynthia gave me, it is listed there. I can also see that it's the most recently created one here at the top, but this is where some of our scheduling team has identified that it can be easy to choose the wrong encounter accidentally. We have a lot that are called pre-home care. They're all, for this patient, under RHS, whether it's PSM or Palliative Home Biz. So there is risk for error there, but I can cross-reference that number and select the right one for the purposes of our demo. And of course, that will populate to RHS Palliative, not VGH. And it's a new visit from Ms. Jody. Pain. And again, all these yellow fields are mandatory. So we're really quick on our triage today, and we're booking her the same day we received it. Of course, we're always in person and off-site in the client's home or in long-term care, which we could call their home as well. And of course, in the scheduling comments here is where we discussed your handover. That could be for the provider. They could click their schedule for the day and see that brief history for the client. Great, we got Dr. Alexiadis at 9:30. That's the one I want. Here's my yellow, which means I'm not quite done. I have to confirm. Now in blue, I'm ready to go. Okay, so that is workflow number 1.
Can I just ask, just for
Monique.
In the interest of time,
yep,
I'm just going to add a few thoughts. So now, one of the reasons why this workflow was an option is that in the beginning, Catherine said it would be important to try to mirror as close to possible the workflow that we currently have now. And so the understanding was that now the PCRNs book the appointment, and then Sabrina does kind of all the computer work stuff. And so, but in the new state, so in Cerner, there's going to be 2 steps involved for a PCRN to book an appointment. So I'm wondering how people would feel about if the PCRNs just block the appointment and then they let Sabrina do all of these other steps, as opposed to PCRN block the appointment, then it goes to Sabrina, then it goes back to the PCRN who does this last little bit, blue. Does anybody have any objections to blocking the appointment and letting Sabrina do all the rest of it? Because you've already selected the appointment.
So it's good that you bring, can you hear me?
Yeah.
Yeah, it's good that you bring that up because it's something we talked about before, actually, as a part of this group in some meeting in the past. And I think what the outcome was like our team can just decide how we want to do that, I'm pretty sure. And as I'm watching the demo here, my exact thought is quite similar in terms of, I know that I'm going to ask the team if we're all okay with just blocking it, putting in the client's information and the reason for the visit, and then having Sabrina kind of do the registration and put it into an actual visit. So,
okay.
Yeah, but I think that's, if that was what we had talked about, right?
Yeah.
You mean in terms of changing the workflow?
Yeah, so let's accept this as let's not even go through option number 2 then, because it doesn't matter. Let's stick with the fact that the PCRNs are going to block it. Sabrina is going to do all the rest, which is basically option 2. So we don't need to go through the whole demo of that. Let's save ourselves some time. Okay.
No, that sounds great. I think that's what the what we are hoping for as well. And as Monica has what you have mentioned, that I think one thing that we do also want to mention that so earlier, instead of using message center to send like a communication to the clerk, what we have also proposed is to place what we call a referral to outpatient order. So this order, the benefit of this order is that it actually brings a lot of those required field that earlier Sarah was filling in, the referring provider, the reason for visit, like, is this like, in person or offsite, the priority, is it next available in 2 weeks and 3 weeks, all those required field are part of the order. So when the PCRM actually place a block appointment, place its to order, and actually really help Sabrina on her side or another clerk if Sabrina's not around to actually then proceed with booking and don't need to fill out all those required field. So I think there's also benefits in that as well. So just wanted to point that out. We don't have to demo it. It will be part of teaching, but I'm glad that we actually all came to consensus in terms of what workflow we're gonna move forwards towards. Knowing that only 3 minutes, we do have some questions for you. So Sarah, I'd let you move over to those outstanding questions for Monique.
Monique, some of these you could gather by email if it's easier for you. In lieu of Catherine's presence, we just need to collect the appropriate person to reach out for each of these clinics while we wait for her return or for interim leadership coverage to be arranged. Is this something that you need to sit on a bit before you let us know for GAM, PSM? Oh, you're just on mute, Monique.
You can reach out to me about those.
Okay, great. And then Cynthia, do you mind just explaining quickly the bookshelf validation for Monique?
Sure, yeah. So previously, it's a little tiny down there, but previously we had the bookshelf, palliative home rolled up under the pain and symptom management bookshelf because the doctors are shared. And so I kind of worked with the pain and symptom management scheduling AA, and I asked if we could create a name that is specific for pain and symptom management and palliative home, since so many things are shared, clerks and doctors and whatnot. So we just updated the name, as you see there, pain and symptom management and palliative home visit clinic, and both books are rolled up underneath those. I think it's just a cleaner look for this area and for anyone looking to see what's booked in there.
Mm-hmm. Yeah, just to add on to it, I think what we're hoping to kind of validate, because previously we actually don't have the palliative home visit as the name on that, what we call the bookshelf. So when we actually look at the name, you don't realize that palliative home is actually within it because it's actually embedded. You actually need to open that plus in order for you to see that palliative home visit, for you to look at the schedule. So so what we have actually recommended is to actually add palliative home visit together with the pain and symptom management name. So that way it's very visible. If someone doesn't know, they look at this, it's like, okay, this is where I will look for the palliative home visit. If it's not there, then it's kind of very confusing for those who are not familiar with the build. So we just wanted to get confirmation.
Yeah, I'm good with that. Anybody have any objections to that on the team? No.
Okay, excellent, Monique. That is all we need, particularly from you. Looks like we're right on the mark for half an hour. So thank you so much for joining.
Thank you. Bye.
Thank you.
The week right through. Excellent. Okay.
Is it okay if I just jump in? I'm so sorry.
Yeah,
I can't find the chat. I also have to leave early today.
Okay.
We're just having a really busy day on our consult service.
Yeah.
And so I apologize. I can't stay for the whole meeting.
That's okay. We put our provider material close to the start as well. So I think we'll be able to cover everything still.
Thank you.
Okay, you're welcome. Excellent. So talking about work lists are places or lists that mostly clerks spend time on looking for tasks that are outstanding, clients who need follow-up in terms of scheduling or perhaps discharge, and it helps that nobody gets missed because the clerk has one place to look for these orders or for these things that need attention. So the examples we have that are appropriate to palliative home visiting, the first being the palliative future request list, ambulatory. Now that we know we are proceeding with the referral to outpatient order, this is where Sabrina or her clerk colleagues will access that order to know, okay, this is a client who needs to be booked. The next one is the past due arrivals. This displays pre-registered encounters. So for example, someone with a pre-home care encounter with an estimated arrival that is 1 day or more in the past. So say somebody sees a patient on Monday and Tuesday, they're still listed as a pre-home care encounter. They were never flipped to a home care encounter. The clerk did not get communication from the physician that the visit happened. This list will be where the clerk can check on a regular basis to see where did the miscommunication happen. Maybe the visit didn't happen. Maybe the client went to the hospital and the physician forgot to communicate that. So that ensures also that those appointments get, there's attention to them. And the last one is the deceased patients with active encounters. To identify patients who have a status of deceased, they may have been deceased at a Vancouver site or have it pulled from EMPI. So of course, you may have booked a patient for next week for a home visit, and as can happen, they get admitted in hospital or hospice or somewhere else, they die in the home, and that gets registered. It can help with avoiding miscommunication around the booking of or the attention and attending of that appointment that they were planning to have but no longer need. All right. So for the name of the bookshelf, this is something we talked about with Monique, so that's just a repetition there. And the location in Cerner will be RHS PAL Home Visit. And we did already agree we're not having appointment reminders for this clinic. So in terms of appointment types, we have our new and our follow-up. We know that follow-up is not typically going to be used. There's some physicians or maybe 1 or 2 that like to do follow-up, so the option will be there, but typically we're looking at the palliative new order or appointment type. And now we know in terms of our workflow, primarily we expect to use that referral to outpatient order initiated by the PCRN. There is another order called accept referral. This was something that we discussed earlier on in our design for this clinic. And even though we don't seem to be using it for our main workflow, we did want to list it as an option that we may see use of down the road. And we can always do some education around that closer to go live as well. Okay, so Megan, I might pass it over to you and you can decide what you want to do for your provider question.
Thank you. Again, this demo is pretty generic. I know Dr. Addo has seen most of these pieces, so just again wanted to highlight just typically in this workflow that folks will come into the ambulatory organizer to look at their schedule for the day. Here I have a patient scheduled to Dr. Addo, so I'm just going to go ahead and click her as the individual resource, but just wanted to highlight that there also is a group resource that has multiple folks on there as well. I'm just going to hit apply here. And here I see the 2 patients that are scheduled for me for this day. And to get into this chart, I'm just going to go ahead and click on my patient's name here, and that will open up the patient's chart for me. I've gone ahead and kind of slimmed down the outpatient chart tab that most physicians will use to do their chart review. And again, just knowing that some of these pieces you may also be reviewing through other means, your current sort of workflow. But if you did want to review through the chart, again, you could probably use your outpatient chart tab and just customize it to see all the different components that you would want to see. I'm not going to spend much time here, just because, again, I feel like we have seen a lot of these kind of similar demos. But you might look in things like their home medications to see, what have they been previously prescribed, sort of what's happening with that. Again, here in some of your documentation sort of sections, again, just typed a few things in here just to highlight the different ways that we can document within our notes within Cerner as physicians. So just typed a few things in here. In our physical exam section, I did a bit of an auto text example that I'll just show again here just for a physical exam. Some physicians do like to use that as a bit of their shorthand. And then again, any active issues that we might add on. So if the patient, we are seeing them for a different chronic issue, for example, that we noticed here in their chart, we might go ahead and add one. So for this patient, let's say the reason of this visit was constipation. I'm going to go ahead and add that for this person here. And again, just kind of documenting our issues for this patient that they may have. And then if I also wanted to get a nice text box to use that in my assessment and plan section, I'm going to go ahead and mark this as a this visit issue as well. And then I'll get a nice box to talk about my assessment and plan for the constipation that I'm going to be doing. So I'll say this is my plan. Prior to launching off our note, I'm also just going to come over to our outpatient quick orders, take a look at our orders and what we might want to place for this patient. I might come through, click on our outpatient prescriptions tab and order a medication for this patient. I did notice that they had some bowel meds, but let's say I wanted to add something on for this person, such as maybe I'll add on a glycerin suppository. Let's say I also wanted to go ahead and order perhaps an abdominal ultrasound for this patient. I'm going to go ahead and click on that order as well. And as I click on these orders, I'm going to notice that my green orders for signature box is going to start tallying up the orders that I have here. I'm going to click on that box and I'm going to go ahead and modify my details. Always looking for my angry blue circles, which tell me that there are information and details missing. So I'm going to click on the suppository here and it's actually asking me for a stop date. So I'll just go ahead and adjust that stop date to be 2 weeks from today's date. And then one other thing I do want to highlight that is a bit different from our previous demos is in this send to information. Previously, this is where we would select the printer. That would obviously be a printed out prescription for the physician to sign and provide to the patient. But now we can also select their preferred pharmacy that we have here to be able to send that eFax prescription directly to them. So in this case, if this patient had their preferred pharmacy listed, I would go ahead likely to select that pharmacy and send it right to them. You'll also notice a few different options down here, such as things like, controlled prescriptions as well, where you would be writing on your triplicate prescription, perhaps using a Cerner label to put that on, but you would be selecting this option if you were, again, writing a triplicate prescription. For today, I'm just going to say do not send other reason because I don't want anything to be sent to the pharmacy.
Can I just confirm with the triplicate prescriptions, can those be eFaxed as well or not yet?
No, they cannot. They're still are going to remain on paper.
Thank you.
Welcome. For the ultrasound, again, just want to highlight a couple of mandatory fields, just the clinical indication. So I'll just type in a reason here, as well as our scheduling location. So you can select any of the locations here, medical imaging sites, for example, Richmond. So from here, if I had adjusted all my details, I'm just going to go ahead and sign off those orders. And then the last step would just be to generate some clinic documentation. So from my outpatient chart tab, likely would leverage my free text note. I know that we don't have a auto text created for this clinic quite yet, but I think that's something that you and I will be able to work on in the future. But just for the purpose of today, I just have this little auto text here that I pulled together just as a bit of a demo. Again, that will pull in different pieces from the chart. This is just based on one that you made with my colleague Jessica, Dr. Addo. Again, pulls in things like our medications, our allergies, some other things that we had in our documentation as well. So if I'm happy with my note, I will go ahead and click sign and submit. If I do want to add on any other providers, I can go ahead and do that by searching just through this search log here. Also in this relationships sub-tab, the primary care physician will always be added here as well. So just wanted to highlight that's a quick way to be able to find that person, or I can also look at some of my other recents or my favorites. Say I want to send this to this nephrologist person, I could double click and it'll just add them to see as a CC. And then I will go ahead. I can also retitle this, which is probably valuable sort of in this setting that you might want to retitle to, home visit note or something along the lines that's just a little bit more descriptive of the visit. And I'll hit sign. Okay, so once I've gone ahead and done that, then my note should also appear here for us. So this note will be able to be seen by other Cerner users as well, just to be able to see the summary of the home visit. Dr. Addo, anything that I can review or anything else that you would like to see in the context of the home visit?
No, I don't think so. I think it's similar to the workflow we looked at before. I don't think I have any other questions.
Okay, great. Hey, thank you.
Dr. Addo, sorry, this is Cynthia. I have a quick question. Just a reminder that we need the schedules because right now, pain and symptom management, I think, is having like you guys every Monday through Friday, and yet you have home care as well. So you don't want to be booked for both in clinic and home visits. So we just need some kind of schedule.
Yeah, I can send the schedule. Can you just clarify what you mean by like being booked in both places?
Yeah, so within the chat book, it will be possible if we don't update it to book a pain and symptom management clinic visit, like at 8 o'clock on a Monday, because that's just how the templates are set, like Monday through Friday, as well as book you like a home visit for palliative home the same day. At 9:30, let's say. So that'd be a little difficult to do. I mean, you may do home visits. You may have like clinics in the morning and then home visits in the afternoon. I don't know, but whatever your schedule really looks like. Right now it's very generic in Chatbook, and I think that might lend to some issues. Unless you're trusting the clerks to know exactly when you're there, but I'm a little worried since since Sabrina's going to have coverage now. She's not. I think she's not going to be the only one doing the bookings.
Yeah, I'm happy to send it. I think like most of the people we work with refer to the schedule so they know which physician is doing home visits and which physician is doing clinic. And so we haven't had issues with that in the past. I think our current system actually allows us to technically be booked in multiple places. But I'm happy to send it if you wanted to work that into the service.
So if it's better for you guys to keep it more open, we can definitely do that. I was still, a little worried that things might get overlapped, but if that's how you do it today and you'd like to keep it more open because your clerks know when which doctors are in and out, then we can do it that way. Absolutely. We'll just leave it the way it is.
I can ask Sabrina what she prefers, if she actually wants it kind of all to be blocked off or if she just prefers to.
Yeah, great.
Yeah. Is she here?
Okay.
Sabrina's apparently off
Yeah, I
sick
don't think she
today,
is.
unfortunately.
Oh.
Yeah, so I think one thing to also keep in mind is that if we can get a schedule from the providers to say like, oh, Dr. Addo is working like Monday, Wednesday, Friday this week, and then Dr. Murphy is going to be working Tuesday and Thursday next week. So that way it's just easier for Sabrina to book. And also like, we can pre-populate those dates in. But even if, for instance, like, Lois, if you decided, oh, actually, I wanted to swap my shift with Dr. Murphy next week, I'm actually going to be working Tuesday and Thursday. Sabrina can still book you by just doing an ad hoc booking for you under your name. So they can still make those changes. We just want to make it as easy as possible
Just
for
saying,
the clerks.
good for you.
Yeah, so either way works. We can keep it open to everyone, or we can keep it open to based on the schedule you provided for us. And then sometimes some clinics prefer to kind of give us their provider schedule like a year ahead, and then we just pre-enter those information in for them. So just make it easier for them. They don't have to figure it out and look at some schedule, just to figure out who's working this week and not, things like that. So it's really clinics make that decision. So we're just here to kind of provide the options.
Yeah, sounds good. I'll forward the schedule. What you'll see on the schedule is just that like every week one physician is assigned to home visits and one physician is assigned to clinic. There isn't like the nuances on it where you can see like, oh, like they'll be doing home visits half a day, but not on this day. Like you won't be able to see that on the schedule. But I can still send the schedule for the week by week schedule.
Sounds good. Thank you.
Thank you.
You're welcome. Who should I send it to?
You can send it. Go ahead.
Yeah, you can send it to me, Lois, because I think you have my email. Okay. And then I'll forward it to the team.
Thank you.
All right, great. So speaking about FormFast, so Joan and Alex, do you remember your educator Laura raising any questions with you around FormFast, specifically the the referral form for hospice and how it's currently living on FormFast in an outdated version? Does that ring a bell? Hey, Joan.
Vaguely.
Vaguely. Okay. Laura was a
Sorry.
I know,
question. That's okay.
Laura emailed us actually to
Yeah.
see to ask whether or not we felt that it would be more valuable to have it on FormFast versus on SharePoint. So I don't know, I can't remember if we've come to a conclusion. I might be biased, but I think we're moving to the SharePoint rather than leaving it on FormFast.
Yeah.
Sorry,
And
what do you mean by SharePoint versus
On the
Yeah.
like just
FormFast.
housing the document there?
in your own drive.
So yeah, for easier accessibility for universally rather than on the FormFast, because I think it would have to be changed in order to be uploaded to FormFast, which is attached to Cerner.
The current one on Cerner FormFast, say for VGH Palliative to access, is the 2017 version. And you've given me the 2021, which has Sea to Sky Hospice on it and just a bit more language as well around admission and agreement. So VGH Palliative actually elected past the 2017 version to just maintain it. They have their own intranet for palliative care, and they've gone that route of hosting it themselves. The plus with the FormFast is that it comes with a patient label pre-affixed when you print it from the patient's chart. And then once it gets scanned back in, it has a unique barcode that tells Cerner this is the admission agreement form, and it gets filed correctly. But the downside is if it ever gets changed, you have to let us know so that we can change it. And the form that is the admission agreement and the hospice referral form that are part of that referral package, those two are eligible and the rest are not. The rest being palliative care benefits, short stay user fee is on there, but anything else that the ministry maintains is not eligible. So now you're going to two places to complete one package. So I can definitely understand why you prefer to host on your own
Right.
drive and have it as one document that you print and fill
Yeah.
it by hand or whichever way. Do you guys need to sit on that a little more and decide? Or
No.
that seems to make sense.
This is ringing all the bells now,
Yeah.
and yes.
Yeah.
That was the
Perfect.
piece, like we can't have the whole package on there.
Exactly.
And
Exactly. The last form that you had given me of the ones that you gave me was the home oxygen program. That one is up to date and in perfect shape on FormFast. So you could get it from there if you wanted to, but I'm sure you've been also accessing it via your own drive as well. Okay. The rest of the forms that you gave me did include things like patient education and clinician information. Those aren't eligible for FormFast as we are uploading just clinical documentation. So that's why we don't have any of those ones uploaded. And like I said, anything from an external agency, so Ministry of Health, palliative care benefits, do not resuscitate, all we can't upload as well. So. All right, so in terms of who are our users in this clinic, I did want to double check. I know we have spoken about resident and medical student participation in PSM. Would we see these clinicians in home visit and see them chart on their own?
yes.
You would. Okay, great. I'm glad I included those. So looking at all these positions here, does it look like we're missing anyone specifically for palliative home visit who provides care or is involved in booking? Looks like we're good. Great.
It looks complete.
The only thing I'll ask about this is are the rest of our home health team is getting Cerner as like view only or read only access, I think is my understanding.
Exactly.
Would they be able to view the physician schedule?
Oh.
Because the nurses have actually
scheduling?
asked us, can they get view only, like read only access to the Jane, which we can't do, or we couldn't,
right.
or we never explored really.
Yeah.
But on the weekend and things like that, it's really helpful for them because we don't have a PCRN on. And so when they're encountering an issue where they need a physician on the weekend, sometimes they're like, okay, well, it could wait till Monday, but they don't know if Monday is already fully booked.
Right.
So it's helpful for them to like kick us an email and say, hey, I see there's a slot here. Is it possible? Blah, blah, blah. Here's what happened. So Stephen and I could potentially follow up on Monday.
Right.
So I could see it being very helpful to give that set of staff read-only access.
Yeah, viewing.
Just
So
a
I
thought.
see you've unmuted. Do you have any insight into that?
That's actually a very good question. I don't think anybody has actually asked that. So that's why I'm like, oh, I'm actually not sure if they will have access to what we call the ambulatory organizer, because the ambulatory organizer is pretty much like, the schedule for the clinic, right? So they would have access to that if they have it. So let us bring it back to see, unless anyone on the call here knows for sure if View and Print has ambulatory organizer.
Yeah, it's Dolores. So view and print only is quite limited. So they can't see like chat book and things like that. They can't book appointments. It's quite limited on what they can do. They can't document technically. So pardon me, we may want to consider giving them the same access as the nurses have, the nurse with reg sketch. Because otherwise
sorry.
No, we only want read
no.
only. Literally just that they could view it and that would be it.
Yeah, so let us double check to see if they have what we call the ambulatory organizer in their position, because that one will just allow them to see the schedule without actually accessing and booking patients and stuff. So, so we'll let us do some checking on that end and let you know.
Yeah, this is just a curiosity. It's not something that we have to, like, if it doesn't exist, it's not something that we necessarily have to even worry about. It would just be a nice to have if it's something they've been asking for. So that's my curiosity.
And I'm pretty sure, sorry, I may be misunderstood, but I'm pretty sure that a view and print only can see ambulatory organizer, and they can see the schedule. Tyler, I think that's correct, right?
I would have to look to confirm.
Yeah, I'm pretty sure, but yeah, we can just double check it.
Okay, yeah, we'll double check and confirm. But if they do have, as what Dolores is saying, the ambulatory organizer, then they will be able to see your schedule. So, so hopefully we'll get you guys some good news soon.
Magic.
Awesome. All right. So for the terms that are used to describe this location in the Cerner world, of course, our full facility name is our RHS Palliative Home Visit Clinic. Unit description is the same, RHS Palliative Home Visit Clinic. And unit display is kind of an abbreviated version of what this clinic's name is, RHS Pal Home Visit. Right. Encounter types, pretty simple. Our pre-home care, which is before the visit has happened. Home care, which is activated once the clerk checks the patient in, which again will typically be done at the end of the day or perhaps the next morning after the physician have done their visits. And once it's been converted to that home care encounter, it will auto discharge itself at midnight. I did add in the phone consult as well. I know occasionally a visit might be scheduled as a phone call, or someone might get bumped to a phone call instead of a home visit. And same as the home care encounter, auto discharges at midnight. Pretty easy here. Medical service, palliative medicine, straightforward. So talking about labels, looks like we still have Dr. Addo here. She and I had a conversation around what she expects to use most frequently. And Jocelyn reminded me that we had spoken at our last session about having a face sheet as an option to be printed, just because it could be a handy document for using as a scratch pad or something to take notes on at the client's home or in long-term care. And then those referral demographics labels, these are the ones that are most useful for using that narcotic triplicate prescription pad. And so if you chose to use Cerner labels for that pad, these would be the ones that would be printed and affixed to each layer of the triplicate. And these are just some screen grabs. Typically we have do not print as checked so that if Sabrina registers people, we're not getting these spit out of the printer every time. But of course, we can populate the face sheet and referral labels into this box of suggestions here. So she's not having to constantly click through every time. And then for clinician printing, through the print label conversation, we kind of got the same messaging. Was most useful would probably be referral demographics. And that could be something that is quickly accessible in that dialog box there. Anything else around labels? Dr. Addo, I know we spoke over email about it, but does anyone else have questions around labels? Looks like we're good. All right, well, we were scheduled for a break. We are about halfway through the slides, so it looks like we might get done in about 2 hours. Is everyone ready maybe just for a 10-minute stretch of the legs? Excellent.
Can I just
Okay.
jump in?
Yeah.
Can I just ask, are we through the provider
Yes.
section at this
Actually, now
point?
we've just hit it with that label, so we're good.
Okay, perfect. Because I might head off during the break,
Yeah,
and
that's
I'll be
okay.
available by email. But
Excellent.
yeah, I won't join again. Thank you.
Thank you. Thank you so much. Okay.
Mhm.
We will see everyone about 2:05 or so. Thanks, everyone.